subject of adjuvant chemotherapy.
Okay, thank you very much to the organizers, and thank you very much, Mr. Chairman. Also, the task. The task that I received is not an easy task. It's the question on the adjuvant chemotherapy after combined modality treatment with with chemoradiotherapy and surgery. There are not so many data in that, so what I will do is take you through some of the data that are available and then do some extrapolations also in this setting and go also over the Cochrane Meta-analysis that was done and published recently on the topic of adjuvant chemotherapy, but this was not precisely on the question as it was asked to me to address. The Cochrane meta-analysis was in patients, the majority of patients didn't receive any preoperative chemoradiotherapy. So therefore I will take you through a little bit an historic perspective and then also comment on some of the data as they were published. It's obvious that, that we have made clear progress in local regional control. There are still some recurrences in that setting. But one of the major challenges is now to try to improve on distant metastasis. And it's clear that still a considerable number of patients do have a metastatic disease after treatment, whichever treatment, surgery plus a combined modality treatment of rectal cancer. And if you look at some of the guidelines as they have been published, they try to summarize some of the data, and if you focus on the postoperative treatment, they indeed state that postoperative chemotherapy can be of value, but they don't go so much in detail, and there is no clear, clear consensus in this setting. What is clear is that the treatment of rectal cancer is evolving, and we are individualizing, personalizing a bit more rectal cancer treatment in this setting. But we are not personalizing very well, and in the different trials we haven't, let's say, a lot of data on the optimal use and the optimal subgroups of patients who may benefit or who don't benefit of adjuvant treatment. I'll come back to the evolving concepts at the end also of rectal cancer, and the previous slide was just some of the actual concepts, and in the future we're going to a more, let's say, individualized and personalized approach. But if we go on the question of the potential role of postoperative chemotherapy, we can say a couple of statements in the beginning. There are data, and there is indirect evidence that postoperative chemoradiotherapy is better than radiotherapy or than surgery alone. That's older studies, 15 years ago. We know that in the postoperative setting, protracted infusion of 5-FU in association with radiotherapy is better than bolus 5-FU. There was an improved survival in this setting. We also have indirect data on adjuvant treatment of rectal cancer, and some people advocate the analogy with colon cancer to cite, not my words, but the words of Dan Heller, for instance, saying you don't treat the left breast in a different way than the right breast. I think we cannot underscore this statement, but some people advocate clearly that there is an analogy for the adjuvant treatment with colon cancer. Preoperative chemoradiotherapy is better than postoperative radiotherapy. That's clear also in this setting. So, and that's why it's difficult to answer the question that the organizers have asked me in a systematic way. The data from randomized trials are not always clear, and in some of the trials there was a suboptimal chemotherapy. If you look, for instance, and I'll come back to that, to the EORTC study led by Dr. Bosset, there was bolus 5-FU as well in combination with radiotherapy as in the postoperative setting. We know that that's not optimal. Many of the trials, and I don't want to criticize the trials, we are all, many of us here in the room are involved of them, but looking backwards to them, the design is not always optimal in this regard. And we have some data on subgroup analysis, but I don't have to convince you that we have to be very careful with subgroup analysis. Some of the older data sets to go historically through the evolution of what we have seen are from different trials in the postoperative setting, comparing postoperative surgery with surgery plus surgery alone, with surgery followed by postoperative radiotherapy, or postoperative chemo, or postoperative chemoradiotherapy. In some of the trials, indeed, with the combined modality treatment after the operation, as I said already earlier on, did show an improvement, and also did show an improvement of postoperative chemoradiotherapy versus radiotherapy alone. This is a data set that I mentioned already, and that is important also in view of the evolution. It's a bit an historical data set, but on bolus versus infused 5-FU during postoperative radiotherapy, showing that infused 5-FU in combination with radiotherapy in the postoperative setting was better than bolus 5-FU. And that's a consideration that we have to take into account looking at all the literature data that we do have, as I mentioned already. Preoperative radiotherapy and preoperative treatment is more optimal than postoperative treatment, that's clear. Preoperative radiotherapy reduces the local recurrence and possibly the survival also added to optimal surgery. And preoperative radiotherapy is less toxic, that's clear. The question is, what does the addition of chemotherapy as well and some other speakers tackled that, so I will not tackle that, as postoperative, does it further improve the outcome of our patients? And then I will take you through some of the data, some individual studies, some meta-analysis in this setting on postoperative chemotherapy. Some of the older studies, the NSABP, the Dutch trial, the GICC study, some of them were quite well-sized studies, looked at the long-term outcome of postoperative chemotherapy. Some trials showed no benefit, some trials as borderline benefits, so difficult to conclude in this setting. But that was also before the era of preoperative radiotherapy. The QUASAR study is a next large data set in this setting, but again with the limitations that it's not of application anymore completely to what we do today for many patients. The QUASAR-2 study was a study of 5-FU based chemotherapy in indications where, in situations where there was an uncertain indication for chemotherapy. Was a randomization between observation and postoperative 5-FU-based chemotherapy, and as well colon cancer patients as rectal cancer patients could be included. There was a mixture, shortcoming of the trial clearly, but a big British pragmatic trial, as our British colleagues do often. Around 30% of patients had rectal cancer, over 70% of patients had colon cancer, but the trial included more than 3,000 patients. And if you look at the trial in these rectal cancer patients, it seems also, or in the total trial, it seems that there was a benefit for recurrence-free survival at longer term and for overall survival in this setting. And also looking in the subgroups of patients, and that's indicated here for risk of recurrence with the red arrow, if you can see it. But it is subgroups of patients on the forest plots. The recurrence-free survival was also better for patients rectal cancer patients who received postoperative chemotherapy compared to patients who didn't receive any postoperative chemotherapy. And the same was true for the survival, and that were mainly stage 2 rectal cancer patients in this subgroup of patients. But the caveat, again, that there was no or very limited preoperative radiotherapy in this group of patients. Our Japanese colleagues have been trying to answer also these questions and have done several individual trials and also a couple of meta-analyses. This is one of the larger and better individual trials in rectal cancer, stage 3 rectal cancers, no adjuvant chemotherapy versus oral UFT-based chemotherapy in rectal cancer patients who underwent a TME surgery. Over 500 patients were included. And in this trial, there was a benefit. And also in one of the 2 Japanese meta-analyses that I could find, there was a benefit for DFS as well as for survival. in a meta-analysis including more than 2,000 patients of adjuvant chemotherapy versus no adjuvant chemotherapy, but again, without preoperative radio or radiochemotherapy in this trial. And a second meta-analysis from our Japanese colleagues, indeed on a larger number of trials, even concluded that there was a similar benefit in colon compared to rectal cancer also, and that's a meta-analysis now published around 10 years ago. Some further trials. The EORTC trial, now also published around 8 years ago, the EORTC trial with different questions, as you know, preoperative radio or chemoradiotherapy in this, and then a second randomization of postoperative chemo or no chemotherapy in this setting. Complex trial, an important trial, but also with some shortcomings, of course. Over 1,000 patients were included in the trial in this setting with this double randomization. And what is relevant here for this topic is just to focus on some of the data of the trial, also on the postoperative chemotherapy. These are the 4 groups. This is the cumulative incidence of local relapse, and you can see that patients who received only radiotherapy, that they had a higher chance of having a relapse. That doesn't answer, of course, the question here that I was addressed to answer. If you look at some further details of this trial, and that's data taken from the New England publication here, there was no significant, sorry for the typo, improvement of overall survival in this setting. If you look at postoperative chemotherapy, that are the 2 groups, versus no postoperative chemotherapy, you can see that there was an improvement, but this improvement was not, this difference was not significant if you look in the whole trial data sets. And that's some further analysis, and then Laurence Collette and other statisticians involved in the trial did some further analysis to try to find out which are the patients that do benefit most from postoperative chemotherapy in this setting. And it seems that especially the patients with who were responding and who were benefiting from the preoperative chemoradiotherapy and who were downsized or downstaged to a lower stage tumor, that especially these patients, that they seems to derive the biggest benefit from the postoperative chemotherapy in this setting. So that's going to be important for the future also, that an important statement in that sense that patients benefiting most from a preoperative chemo or chemoradiotherapy, that they seems to derive the biggest benefit also from the postoperative chemotherapy in this regard. And that's in fact what is shown in these different slides here that are shown, that the efficacy of adjuvant 5-FU-based chemotherapy, this is all about 5-FU, this is not about oxaliplatin, in the patients during the operation, a staging of a T0, T1 or T2 on overall survival suggested, but did not conclude affirmative. The sample size becomes too small in these subgroups, but suggested a bigger benefit in these subgroups of patients in this setting. Looking further at some of the subgroups in this EORTC study also, is that this benefit of adjuvant chemotherapy was seen in the subgroup of patients receiving more the preoperative radiotherapy alone, but looking at the statistical analysis was not so clear there in the patients receiving the preoperative combined modality treatment. So that's some of the subgroups, and again we have to be careful with this, some of these statements and some of this subgroups analysis. But the bottom line message in the EORTC study is that that patients benefiting most of a preoperative treatment, that is a subgroup of patients that benefited most of a postoperative chemotherapy. Last year, or in 2012, there was a Cochrane meta-analysis also published on adjuvant treatment in rectal cancer. 21 eligible randomized controlled trials. More than 9,000 patients with rectal cancer were included. Almost 5,000 patients in the group of surgery plus chemotherapy, and also a large number of patients in the group of surgery plus observation in this setting. So large data set, but the big caveat or the big, let's say, shortcoming of this analysis for modern treatments is the lack of individualization, and also that this was the majority of patients, not all, but the majority of patients did not receive a preoperative treatment, whether it was chemo, whether it was radiotherapy, or whether it was chemoradiotherapy. So there are some limitations, clearly some limitations on this Cochrane meta-analysis. But I'll take you through some of the data as they were published in 2012 in this paper. This is a forest plot looking at survival in all studies included. And I summarized on the bottom, there was a risk reduction of 17%. The hazard ratio was 0.3 in favor of adjuvant 5-FU-based, it was without oxaliplatin, just adjuvant 5-FU-based chemotherapy in this setting. Looking at the larger studies for different reasons, excluding the smaller studies, looking at larger studies, and larger studies was defined as studies where there were at least 100 patients per arm, there was a risk reduction of 15%, so very similar to the previous slide. Hazard ratio in the larger studies of 0.85. Looking at the Western studies also, so they did all different types of analysis, and I'll take you fast through that. There was a risk reduction of 18%, and that's all for survival. Looking at the Japanese studies, there was a risk reduction of 15%, so all in a similar range, and that's again all for survival in this setting. Looking at the subgroups here for stage 2 and stage 3, the upper line is for stage 2. The lower graphs forest plot is for stage 3 rectal cancer. And again, most of the patients were without preoperative radiotherapy. In this setting for stage 2, it seems that there was a bigger benefit than for stage 3. And I'm sure that the weight of the QUASAR study that I summarized already contributed clearly to that. Also, this study was included in that analysis. This is again then looking at disease-free survival. Similar messages. You can see that the hazard ratio for disease-free survival in all studies included was 0.75, so risk reduction of 25%. The larger studies for disease-free survival, 0.79, risk reduction of 21%. The Western studies, risk reduction for disease-free survival of 23%, hazard ratio of 0.77. And again, also for stage 2 on top, stage 3 on the bottom. Here you can see that for DFS, in both groups of patients, there was a clear benefit for adjuvant chemotherapy in this setting, but again with caveats that I mentioned several times. So this Cochrane meta-analysis on adjuvant chemotherapy in rectal cancer is a large meta-analysis that supports on an evidence-based way the use of postoperative 5-FU-based chemotherapy after complete resection of non-metastatic rectal cancer. But again, these data do not take into account and do not answer the question, what is the real benefit of postoperative chemotherapy in patients who underwent already and who received a preoperative chemoradiotherapy. And these data also did not study, or this analysis did not study the role of adjuvant oxaliplatin in patients not exposed to that in the preoperative setting. There were a couple of newer studies. The Chronicle study, Rob Glyn-Jones, the PI, is in the room here. This study was planned to randomize 800 patients, locally advanced rectal cancer, preoperative chemoradiotherapy, R0 resection, and then there was a randomization of follow-up or postoperative capecitabine oxaliplatin. The intention was to include 800 patients. The study was stopped after over 100 patients. The disease-free survival here, there was a trend for disease-free survival, but because, of course, low number of patients, this trend was not statistically significant in this situation. There was no difference in survival, neither what we can expect, of course, in such a low number of patients. And that are the conclusions of Bob Glyn-Jones as he presented that in the past at the ESMO GI in Barcelona. The trial was closed after 113 patients. To have a formal answer to the question that the chairman asked me to address, there was no significant differences in outcomes. There was a poor compliance to postoperative oxaliplatin chemotherapy following chemoradiation. And as I mentioned, the hazard ratio for DFS was 0.8 in this setting. Different groups, NSEBP, PETAC, and Hans-Joachim already summarized some of the data. They don't answer clearly the question that I was posed, but they complete, let's say, the complete field in this setting. We don't have any data on oxaliplatin. In rectal cancer, specifically oxaliplatin-based chemotherapy, with the exception of Bob Glyn-Jones' study in this setting. So we have to do some extrapolations. We know that chemotherapy, and I here summarize some of the conclusions of the expert discussion in the framework of the ESMO GI meeting. Chemotherapy is active in adjuvant treatment of high-risk rectal cancer as it is in colon cancer, even if direct proof of efficacy are limited. Most of the patients who received the preoperative radiotherapy or chemoradiotherapy are candidates for postoperative chemotherapy. That's not, well, that's expert opinion. And there we clearly can comment on some of the issues and some of the, let's say, data sets in this setting. Should we differentiate stage 3, stage 2 in this setting? What about, and I alluded to that, responders to neoadjuvant chemotherapy? They seem to be to benefit most, at least according to Jean-François Bosset's EORTC study in this setting. We have very little data on oxaliplatin in this setting. What is clear is that at least from some of the situations, that at least there can be no recommendation with the data that we have, and I agree completely with Hans-Joachim Small, to include oxaliplatin in patients with non-metastatic rectal cancer in addition to chemorad in the preoperative setting. But the answer and the question, one of the questions is, what should we do with some specific situations? For instance, patients who received a preoperative chemo 5FU or capecitabine-based chemoradiotherapy in the preoperative setting, if they benefited from the chemorad 5FU-based chemorad, I don't think there is an indication right now with the data that we do have to expose these patients in the postoperative situation to oxaliplatin-based chemotherapy. I do think that there is an indication to expose these patients and to propose them to an adjuvant 5FU-based chemotherapy if they had a good response based on some of the data that I explained to you. The question is, what do we do in patients who received fluoropyrimidine-based chemorad in the preoperative setting and who still have, for instance, a stage 3 rectal cancer, so who didn't show a lot of signs of downsizing or downstaging, so who still have a T3 and 1 tumor. Should we give them oxaliplatin-based chemotherapy, yes or no, in this setting? We don't have a final proof. We don't have data from randomized settings and studies. But I think based on an expert opinion that we could defend to propose this subgroup of patients also more intensified chemotherapy with oxaliplatin because they didn't benefit, for instance, on 5FU or capecitabine plus radiotherapy in the preoperative setting. Based also on some extrapolations with colon cancer in this setting, based on the facts also that we know that these patients have a high likelihood of recurrence, but the evidence in this setting is not higher than an expert opinion in this setting, and so that can be challenged, and I'm sure that not all experts have the same opinion in this situation. And so to conclude, the treatment of rectal cancer is clearly going forward. That's a topic of many of the different talks. The adjuvant postoperative chemotherapy is one of the components in this multimodality treatment where we want to try to improve the long-term outcome, where we try to avoid metastatic disease at longer term. In many of the, let's say, potential future algorithms, it is included. which is probably correct, but we will have to personalize, we will have to individualize also, as we are discussing a lot on individualizing and personalizing the treatment in the preoperative setting. In the postoperative setting, we will have to do that also with molecular markers, also with looking at some subgroups in the trials and then trying to build on that further work for the future. Thank you for your attention.